My name is Anna Holcomb, and I am a staff development nurse in the neonatal ICU at Methodist Women's Hospital. I have to give a shout out to Sherry Kimmy, who also participated in the creation of this PowerPoint. She is our clinical nurse educator up in outreach for the NICU. Today we're going to talk about neonatal hyperbilirubinemia. And these are just some of the objectives that we are going to have for today. They're not too complicated, and hopefully by the end of the day you will be able to do all of them. The first one is understand bilirubin metabolism, differentiate between unconjugated and conjugated bilirubin, describe the most common causes of hyperbilirubinemia in the term and the preterm infant populations. We'll be talking about both, kind of jumping back and forth. Evaluate the risk factors for hyperbilirubinemia and understand management techniques for hyperbilirubinemia in the preterm and term infant. So I just wanted to start with just kind of breaking down the word. That seems kind of a simple place to start, but sometimes that's the way I understand things the best. So if we take hyper, that means too much. Bilirubin, we'll talk more about this, but it's a byproduct of red blood cell breakdown. And anything with the word emia at the end means that the condition is present in the blood. So neonatal obviously talks about the population, and then hyperbilirubinemia is just too much bilirubin in the blood. And this can result kind of as a result of these three mechanisms. Increased rate of bilirubin production is the first one. And we'll kind of talk more about towards kind of the halfway, 3/4 way through the PowerPoint, the different conditions that kind of go under each of these headings, but these are kind of the three main concepts for why you would have too much bilirubin in your blood. So you have an increased rate of bilirubin production. You have reabsorption of bilirubin into the plasma from the gut, or this is called enterohepatic circulation. And the third one is an inability of the liver to clear sufficient bilirubin from the plasma. So those kind of three mechanisms we'll be kind of referring back to as we go through this. I don't want this diagram to scare you. I'm a visual person, and so I like diagrams, as you'll see throughout the PowerPoint. I also think a picture is worth 1,000 words, and I'm sure we've got some visual learners out there, so this is for you. We have to talk about physiology for just a second. I know it's not everybody's favorite part, but we have to just chat about it for a minute because it is important for understanding, like, what is bilirubin, where does it come from? So we're just going to kind of start at the top, just a brief overview of the physiology part of it. So you have heme breakdown two different ways. So you have 75% of the heme over there is just catabolism, of the red blood cell, which is the majority of where your heme comes from. And then on the other side is the 25% that's left. And that's just from other things. We're not really going to talk about that because the majority of the disease processes we're going to talk about is going to be more of just the breakdown of red blood cells. So once heme is broken down, it interacts with an enzyme to then form biliverdin as you kind of work your way down. Biliverdin is then broken down by an enzyme to bilirubin. Now I have this circled with red because this is kind of a key point in the process, because this now, after this biliverdin has interacted with this biliverdin reductase, it is now unconjugated bilirubin. So it's kind of the stuff that causes the majority of our hyperbilirubinemia scenarios in our neonates. So it's kind of an important point in this bilirubin cycle. So once you have bilirubin, then it has to get to the liver somehow. So it kind of hooks up with albumin, And we know that albumin is just a large protein in our blood, and albumin carries bilirubin to the liver. So we have bound bilirubin bound to albumin. It's now in the liver, where it meets up with an enzyme called uridine glucuronidase transferase. And we're going to refer to that from now on, because I've said it once and I'm not going to say it again, as UGT. So it meets up with UGT and also this ligandin, which is a bilirubin binding protein in the hepatocyte. So in a liver cell, there is this bilirubin binding protein ligandin and this enzyme UGT. The enzyme conjugates bilirubin, so it's really important. So I have it circled again. And it now, because it's conjugated, is water soluble, and that means that the body can get rid of it. So the bilirubin that is conjugated is now, keep moving down the diagram, transported via the bile to the small intestine, where it can now be excreted from the body through urine and feces. One thing to kind of point out, it's this kind of dotted line out to the side, the intrahepatic circulation. And you see that it leads from the small intestine kind of up back to this bilirubin section where before it combines with albumin and is taken back to the liver. So there is a small amount of bilirubin, conjugated bilirubin, that sits in the small intestine until it can be converted, or I'm sorry, it has the potential to be converted back to an unconjugated form of bilirubin, and can cause problems, as we'll kind of talk about more as we go through. There is an enzyme down there in the small intestine called beta-glucuronidase, and that has to do with the reabsorption and also just kind of the bacteria properties of the gut of our term and our preterm babies. Okay, so we're done with that slide. We get to move on. Just to the right here is kind of a short synopsis of kind of what I said. What is bilirubin? End product of catabolism of heme, primarily from circulating hemoglobin or red blood cells. 75% of bilirubin in neonates is from breakdown of red blood cells. So that's kind of what we're going to be talking about the most. And this in the bold in the very bottom, bilirubin must be converted to a water-soluble form before it can be excreted. So up here at the very top, I hope you can see my mouse, where you have this bilirubin here. So this is not conjugated. This is not water-soluble yet. It's not water-soluble and conjugated until it reaches the liver. So this is kind of where it can cause problems because there's no place for it to go but stay in the bloodstream, and it causes problems when there's too much of it in there. So moving on, I have a little video that I wanted to play for you just to kind of break things up. It's kind of a synopsis of what we sort of just talked about, but it's just says it in a different way, and I thought it was good, so I wanted to play it for you.
Jaundice, which doesn't have the most intuitive name, comes from the French jaunisse, meaning yellowing. It's also sometimes referred to as icterus, though, the origin of which is even less intuitive, coming from the thought that jaundice could once be cured by looking at a yellow bird. Well, the more you know, right? Anyways, as you've probably gathered, jaundice involves someone taking on yellow pigments, specifically in the skin and eyes. The yellowing pigment is caused by a compound called bilirubin, a component of bile and the main cause of bruises being yellow, and after its metabolism, the yellowness of urine and brownness of feces. So since bilirubin's our main culprit of yellowness, it's super important to know where it comes from. As red blood cells near the end of their lifespan, which is about 120 days, they're eaten up or phagocytized by macrophages in the reticuloendothelial system, aka the macrophage system, where the spleen plays the largest part, but it's also made of parts of the lymph nodes. Okay, so first the macrophage eats up the blood cell. and hemoglobin is broken up into heme and globin. The globin is further broken into amino acids. The heme, on the other hand, is split into iron and protoporphyrin. Protoporphyrin is then converted into unconjugated bilirubin, or UCB for short. Unconjugated bilirubin is the form of bilirubin that's lipid soluble, meaning it's not water soluble, right? Albumin in the blood then binds to unconjugated bilirubin and gives it a lift over to the liver, where it's taken up by hepatocytes and eventually conjugated by an enzyme called uridine glucuronyl transferase, or UGT, making it now water soluble. At this point, the conjugated bilirubin is secreted out into the bile caniculi, where it drains into the bile ducts and is sent to the gallbladder for storage as bile. Now, when you eat a donut or something, your gallbladder secretes the bile, which has the conjugated bilirubin in it, and it moves through the common bile duct to the duodenum of the small intestine and is converted into urobilinogen, or UBG, by intestinal microbes in the gut.
Now some of that urobilinogen is reduced to stercobilin, which is excreted and responsible for the brown color of feces. Some of that urobilinogen is actually recycled though, and it gets reabsorbed into the blood and spontaneously oxidizes into urobilin, most of which is sent to the liver and some of which goes to the kidneys. It's then excreted and is responsible for the yellowness of urine. And there you have it, bilirubin metabolism in a nutshell.
Now, if some point in this...
Okay, we're going to stop there. We'll go back to this video actually later, because there's another part to it that I think is helpful. Sorry, bear with me. I'm just kind of using two computers here. I got to get to the right spot. So here's some bilirubin facts for you, just to kind of sum up kind of what we talked about so far and move on just a little bit. So bilirubin is the normal metabolic end product of red blood cells. So an average lifespan, like the video said, for an adult red blood cell is about 120 days. But remember, our infants are a little bit less than that, about 70 to 90 days. Preterm babies, micropreemies even, extremely low birth weight babies, very low birth weight babies. These kids can even have as low as like 60-day lifespans for their red blood cells. So not as long, and more red blood cell turnover, more red blood cell breakdown, you're going to have more bilirubin kind of floating around. Albumin carries the bilirubin to the liver. We talked about that. Bilirubin is higher in infants due to the high turnover and shorter lifespan of red blood cells. Preemies, again, break down red blood cells faster and have immature livers. Once transferred to the liver, conjugated indirect bili, so we'll kind of talk about those two terms later, is converted to conjugated or direct bilirubin and then can be excreted from the body. If production exceeds the liver's ability to conjugate or eliminate bilirubin, or let's say you have these albumin binding sites and they're all saturated with unconjugated bilirubin, the level will then in turn rise in the blood and you will have jaundice that develops, right? So we always have a certain amount of bilirubin, it's just natural, it's physiologic. We just always have this red blood cell breakdown and maintenance. So we always have a certain amount of bilirubin. And then there's actually, in some literature, there's, some protective effects of a certain amount of bilirubin in the blood, which we're not going to talk about today, but kind of just as a side note. So it's natural to have it be in the blood, but it's when we have some faulty things that are going on, like we have immature body systems, organ systems, liver, that can't eliminate or conjugate effectively, or we're deficient in something that we need an enzyme to conjugate, then we get into this this imbalance, and we have a lot of extra unconjugated bilirubin, or in some cases conjugated, depending on kind of the disease process itself, and jaundice develops, or the yellowing of the skin, and we'll kind of talk more about that. And then there are some medications, none of which we give in the NICU, that do compete with bilirubin. They compete by binding to albumin, and so then there's not enough albumin for the bilirubin to bind to, and that can kind of raise your bilirubin. So that's why we don't use them in the NICU. We're not really going to go over them specifically, but Just so you know, there are certain kinds of drugs that will do that. So these are the different types. There's actually 4 different types of bilirubin. There's conjugated bilirubin, and the 2 bold ones, I'll say they're the most commonly referred to bilirubin types, and we'll be referring to them over and over today. But there are actually 4 types. So conjugated bilirubin, which can be excreted, it's water soluble, can be excreted in the urine and the feces. There is conjugated covalently bound bilirubin, which isn't really found in neonates that are less than 2 weeks old, so we're not really going to spend any time on that one. There's unconjugated bilirubin, which is lipid soluble, cannot be excreted from the body, and is reversibly bound to albumin. And then there's free albumin, which, if you kind of think back to that diagram pathway that I had, that's the bilirubin that is unconjugated and it's unbound. So it hasn't yet been taken up by the bilirubin, or I'm sorry, by albumin to be transferred to the liver. So it's just kind of floating around freely in the blood, is kind of how I remember it. And it is the one that can do some nasty damage to the brain, which we'll talk about later. And so I kind of wanted to put it here. So when we talk about the most commonly found clinical conditions associated with hyperbilirubinemia in infants, we're primarily talking about unconjugated and conjugated, and then free bilirubin. So those terms you'll need to kind of remember, and hopefully will make a lot more sense when we're done today, if they don't already. We'll focus a little bit more on the 2 most commonly referred to and heard about types of bilirubin, unconjugated or indirect bilirubin. Those terms can be used interchangeably. And conjugated or direct bilirubin, again, you will hear those terms kind of used interchangeably. In literature, we'll kind of use them interchangeably. When we check labs, we will often check a direct bilirubin level as opposed to a conjugated bilirubin level. It's the same thing. We're just using one term versus the other. So I'll try to stick to unconjugated and conjugated just to help with the differentiation during this presentation. So each type has different qualities, obviously, and that determines how they affect the body. Kind of starting close to the beginning of the bilirubin metabolism diagram that we kind of first looked at. When you're talking about unconjugated bilirubin, it's lipid soluble. It can cross the blood-brain barrier. I have a bunch of stars there because I'm going to go back to that in just a second. Unconjugated fetal bilirubin is transported across the placenta and excreted by the maternal circulation. And I think this is just kind of good to mention because while in utero, bilirubin is never really a problem. I say that because there are some situations where you have a lot of hemolysis going on, and so the baby's bilirubin level is sort of high, but the mom does such a good job, and unconjugated bilirubin readily transports across the placenta. And so the mom's liver can really do the majority of the work to conjugate and then excrete the bilirubin, no matter what kind of hemolysis rate you have going on in your baby. So just kind of something to keep in mind, that the problem for this doesn't really show up to where it needs an intervention for the bilirubin, hyperbilirubinemia part of it, until after the baby is born. You might have to address the anemic side of things, which we'll kind of talk about more, how like you kind of have to think about anemia always with hyperbilirubinemia. We'll talk about that later, but the mom does the majority of the work when the baby's in utero, and so baby's protected. You have to convert unconjugated bilirubin to conjugated before you can excrete it. We've said that multiple times. We'll say it multiple times more because it's an important concept to grasp. And then once conjugated, bilirubin passes through the intestines and then can be excreted. And phototherapy does work when you've got an unconjugated hyperbilirubinemia, as opposed to conjugated, which is water soluble and can be excreted. So it's after it's had interaction with that UGT enzyme in the liver, conjugates, goes into the gallbladder for storage, transports to the small intestine via the bile duct, and now is in the small intestine where it interacts some more with some enzymes and some bacteria, and it can be excreted in the feces and the urine, also found in the liver. But at this point, phototherapy is not helpful because of the molecular properties of conjugated bilirubin. It's no longer helpful if a baby has a high conjugated bilirubin level. Phototherapy is not going to do anything, and actually it's going to harm the baby. It can actually change the color of the baby's skin if you use phototherapy when you've got a conjugated hyperbilirubinemia happening. Okay, back to the stars here. So this is where free bilirubin kind of comes into play, because what crosses the blood-brain barrier and causes problems with staining of the brain matter is this free bilirubin. You have this scenario, let's say, where albumin binding sites are saturated, and then unconjugated bilirubin circulates, right, as free bilirubin. It can't conjugate, or it can't connect to albumin. All the sites are saturated. Maybe you've got a low albumin. Maybe you've got so much bilirubin that you just don't have any albumin left to take you to the liver. So you're floating around as free bilirubin, and you can cross easily into the blood. You can cross the blood-brain barrier. And this bilirubin then deposits in the brain's fatty tissue, right? It's lipid soluble. It loves fatty tissue. And your brain is very fat. So it goes over, deposits in the brain's fatty tissue, and essentially staining the tissue. It stains it kind of a yellow color, and can cause a lot of problems because it can be very toxic to the brain tissue. And it causes a set of clinical symptoms that we see as acute bilirubin encephalopathy. And then when we talk about like a diagnosis, we call this kernicterus. So what we see clinically is the neonatal encephalopathy, right? And then as we kind of figure out the etiology behind that and where this brain toxicity is coming from, then we can do an MRI and talk more about it being kernicterus. So when it's left untreated, this free bilirubin is just crossing the blood-brain barrier, depositing in the brain tissue. When it's untreated and just unabated, this toxicity can really lead to permanent neurologic impairment that you will hear as kernicterus, and it's nasty, and it's got terrible outcomes, including death. And we will touch on it a little bit later, but I wanted to just kind of make the differentiation between what is really causing the brain toxic effects. So it's that free bilirubin. This is just another way to look at the different types of bilirubin, the unconjugated and the conjugated. Just as in table form, there's no real new information on this slide. It just talks about the characteristics of it, kind of where it's found. So again, indirect bilirubin is lipid soluble. It can be unbound as free bilirubin or bound to albumin. Free bilirubin circulates in the bloodstream and can cross the blood-brain barrier. And then bound bilirubin to albumin is how it gets to the liver, where the enzymes aren't conjugated, so the body can get rid of it. Phototherapy does help in getting rid of this unconjugated hyperbilirubin or unconjugated bilirubin. And then just again, the free bilirubin can cause effects to the brain, as we have already talked about. And it likes to deposit in fatty tissues like the brain, like the skin, and especially like the sclera. Sclera is really lipid dense, and the free bilirubin and the unconjugated bilirubin love to just nestle right in there and make your eyes look really yellow. So kind of the first place that jaundice will show up is in the eyes, the sclera. And then direct or conjugated bilirubin, it's water soluble. It's found in the liver, not oh, that is a typo. That should say water soluble. I'm so sorry about that. Of course, I've read this a million times and just am catching this. And just scratch out this whole second thing. It is water soluble, and it's already been in contact with the enzyme UGT, and so that is the way it is going to be excreted then, because it is now water soluble and can be pooped and peed out by the baby. And phototherapy, this is correct, cannot assist with this type. I'm so sorry about that, you guys. So no phototherapy, and then sometimes you'll see kind of a buildup of this conjugated bilirubin in the liver, especially if you've got kind of something going on with your liver or your biliary tract. It can kind of cause some gallbladder sludging. Okay, so we can kind of speak in general terms and say that an infant has hyperbilirubinemia, or depending on kind of what's going on with the baby, how old they are, and what their lab values are, we can narrow it down a little bit and either say they've got an unconjugated or indirect hyperbilirubinemia or a direct conjugated hyperbilirubinemia. Total serum bilirubin is the lab that you will see most commonly drawn to check for this condition, and it measures both unconjugated and conjugated bilirubin. There are some conditions where a direct or a conjugated bilirubin level is helpful for determining the disease processes, or sometimes you'll see providers order what's called a fractionated bilirubin level, which is kind of just a breakdown in the percentages of direct conjugated versus indirect unconjugated. So abnormal values with total serum bili will vary. They'll just differ by gestational age and whether there's other illnesses or conditions present. We talked about it being a combination. And then jaundice or icterus is just kind of a generalized term describing the yellowish coloration of skin and sclera caused by higher concentrations of bilirubin. Usually babies will kind of look a little jaundiced when levels appear at about 6 to 7, or when levels are around 6 to 7, and it appears in a head to toe fashion, and it regresses in the reverse order. So you'll kind of start with the eyes and the head and move down towards the feet as your bilirubin level increases and gets worse, and then as your bilirubin level decreases and gets better because we're treating the baby, or the liver starts working a little better, or the baby starts pooping and peeing more, then you'll kind of see it reverse from toes. Kind of the head and the eyes is the last place you'll see it disappear. And just remembering that this is such an important topic because this is really the most common condition requiring treatment found in neonates. So you'll see it all the time. It's very common, and it will kind of become second nature to you as NICU nurses, but remember that it's a little confusing for parents, and so it's good to understand it so you can be a good resource for them to kind of explain what's going on with their baby. So who is at risk for neonatal hyperbilirubinemia? Kids that are from a East Asian or Mediterranean descent are at higher risk. So you've got some ethnicity that will play a little bit of role in whether you may or may not become more jaundice. Delayed cord clamping, that does increase the hematocrit of the baby at birth. So it can increase the level of bilirubin that you have. If you have more red blood cells, you're going to have more red blood cell breakdown, and you're going to have more bilirubin. Just sort of a caveat to that is that the studies studying delayed cord clamping, we do it because the benefits are so good, and the increase in bilirubin was not significant enough to cause anybody, sleep at night or cause us to treat any more babies than we were kind of already treating. So if you've got a sibling with jaundice or was treated for jaundice, then you're at risk for needing treatment yourself. Asphyxia, does anybody have any idea why asphyxia would cause hyperbilirubinemia? Just kind of think about that for a second and see if you can come up with maybe a why as to why asphyxia would cause hyperbilirubinemia in our babies. So asphyxia, if you think about what happens when that's occurring, you have reduced oxygen and blood flow to organs, and in turn you have organ injury and possibly dysfunction, especially to a organ called the liver, which is important when we're talking about hyperbilirubinemia. And so a lot of our babies who are asphyxiated and have taken kind of a hit, if you will, to their liver, so they've had some injury, whether just transient or permanent, if it's really bad, usually just transient, you will see these babies struggle with hyperbilirubinemia and often need treatment because their livers just aren't up to snuff in the moment to get rid of that bilirubin. Infant of a diabetic mother. So these babies, they have increased body mass, right? I mean, they're just chunky, huge. We've all seen them. And increased body mass requires more blood flow, and this requires more red blood cell production. So these babies are often born and shortly after birth, and they're plethoric or ruddy. They've got high hematocrits, which just in turn leads to more red blood cell breakdown and increasing bilirubin loads or levels. So you'll see it in that population as well. Any type of extravasite, I can't pronounce words sometimes, so we're just going to say like bruising, right? You've got a kid with cephalohematoma, intracranial hemorrhage, or let's say mom abrupted and they've swallowed a lot of blood. So they've got extra blood on board. These kids are going to have a higher bilirubin because they've got more red blood cell load, and so they're going to have more red blood cell breakdown. There's some maternal medications, Pitocin and Bupivacaine, that can cause infants to have a higher bilirubin level at birth. And then we'll talk about more this ABO and RH incompatibilities and some other isoimmune hemolytic conditions that can cause hyperbilirubinemia. We'll talk more about that later. Of course, if they have any hepatic dysfunction, they're premature, they're asphyxiated like we talked about. I think it's important to remember that there might not be anything wrong with our babies. They might just be premature, but because their liver's not functioning completely normal yet, that just kind of plays a role in whether they're able to process the bilirubin or not. And then poor feeding, related to intrahepatic reabsorption. So either they're not eating very much or their gut's not really moving very, very efficiently. And that bilirubin that's conjugated is just kind of sitting in there, sitting in that small intestine. It's not really moving around, not really moving along. It's going to interact with that enzyme that's in there more often than not. You're going to have more of that kind of reuptake back to unconjugated bilirubin through your intrahepatic reabsorption system. And then our kiddos that are exclusively breastfeeding, these kids will be more at risk for neonatal hyperbilirubinemia just because they're just not taking in the volume. So more associated in this scenario with babies that have a kind of a weight loss of like 8 to 10%, but just to kind of keep in the back of your head that these kids can be at higher risk too. So preterm versus term, I said we'd kind of talk about these two groups of infants and the differences and this kind of the similarities too. Just kind of taking a glance at the table, you can see that preterm infants are kind of at a disadvantage. They have delayed feedings often. They spend more time being NPO for different reasons. Poor hydration status, so whether that's just because they've got a ton of insensible water loss because they're extremely low birth weight infants, or because, their kidneys are not working very much, so they're having a lot of output or diuresis, or there's lots of different ways their hydration status can kind of alter. And we play a lot of catch up in the first week or so of life for these preterm infants, kind of trying to stay, keep them in kind of a neutral zone with their hydration. Immature hepatocytes, immature liver, your hepatocytes just aren't functioning because you're early. You weren't ready to be born yet. Your liver's like trying to work, but just can't get it together. Increase in intrahepatic circulation. We kind of just talked about that. You've got delayed feedings or NPO. So you kind of have this sluggish gut, which means you have this conjugated water-soluble bilirubin that's sort of sitting in the small intestine instead of moving through, and it's kind of reabsorbed via that enzyme activity, and the intrahepatic circulation will just take that back up and unconjugate it. And then it has to go through the whole system again, get back to the liver. It's like a vicious cycle. Decreased albumin sites, and this can be just because they're little. They've just got decreased in albumin levels. Shortened red blood cell lifespan, which is kind of what we talked about already. And then, just a lower amount of serum albumin. That's kind of a duplication. I knew I was going to find mistakes in this PowerPoint, even though I've looked at it a million times, so I apologize for the errors. And then term infants, they have better organ function. They have improved hydration, usually in the first kind of couple of days. They have usually early initiation of feedings right away. And then their red blood cell, even though it's shorter than adults, it's not as short as our preterm infants. So, and then I kind of put these bolded, they're the same in both categories because both term and preterm infants kind of struggle with decrease in bacteria stores in the gut, and then an increased activity in this beta glucuronidase, which that is that enzyme that's in the small intestine that can unconjugate that bilirubin, and it can be retaken back up via the intrahepatic circulation back up into the bloodstream. And then they have a deficiency of the ligandin, which is that predominant conjugating protein in the liver. So both populations kind of struggle with those two things. So I just wanted to pose a question, and I know you're listening to this, so it's not like I'm in front of you, but what do you think? Just think about this. Do you think, does the severity of jaundice, so you look at a baby and you're like, man, that kid is a pumpkin, like just so jaundice. Is that a good indicator that they may be in need of phototherapy? Just kind of think about that and let that kind of mull in your brain. The answer to that is really no. I mean, when we're talking more about the term population, you will hear providers talk about, if the baby looks more jaundiced, like maybe we'll check a serum bili. So it can be an indicator that the bilirubin is increasing, obviously, but it's not really an indication for phototherapy. Like you can't look at a baby and say, that baby's bili's 13, we're going to put him on phototherapy. So jaundice is a pretty common term, and hyperbilirubinemia is the medical term for jaundice. It's a clinical sign. So by that, I mean that it's just because a baby's jaundice doesn't mean that they are experiencing a pathologic event that requires medical intervention. And we talked about the difference, that there is a difference between term and preterm infants and kind of their abilities to deal with an increased bilirubin load due to risk factors that we kind of looked at in the previous slide. So when an infant is jaundiced, it can give the clinician a clue, especially if you're talking about a baby in newborn nursery, that maybe we need to check a serum or at least a transcutaneous bilirubin, but not really something that we can look and say, yeah, we need phototherapy because that baby's so jaundiced. So signs and symptoms obviously is a yellow and orange discoloration of the skin and sclera. And like I talked about, the sclera will be the one that will show up first. These babies can be lethargic, and that's kind of scary a little bit because the lethargy has to do with your brain, and that can be a kind of a neurologic sign. So that to me is a little bit scary if you have a jaundiced lethargic baby. And then they can be poor eaters. So these kids, they need to eat because they need to poop and they need to pee and they need to get their gut going, but they usually are poor eaters. And then this is just some medical management for an infant that's found to be jaundiced, kind of a general list. We'll talk more about the labs as we talk about pathologic hyperbilirubinemia conditions. But these are some of the common labs that you'll see ordered for a baby that has jaundice. Increasing in hydration, early feedings with good hydration are both things that are going to help in that excretion of bilirubin. They're going to stool more, which is going to help get rid of that bilirubin probably the most. And good hydration is going to increase your urinary excretion of the urobilinogen, which we kind of talked about earlier. And then phototherapy is something that we commonly do for these babies. It's non-invasive. Usually parents are pretty familiar with it, and the babies don't mind it terribly, although some hate it more than others. Mostly the mask, not the light itself, but you will commonly see that done in managing your baby with hyperbilirubinemia. Okay, this slide, I just really think that there are some terms and some things that you have to think about when you're talking about hyperbilirubinemia that are important to kind of understand hyperbilirubinemia. So when you're talking about the level of bilirubin that the baby has, you have to think about the timing, you have to think about the onset and the rate of rise. So that's kind of over a couple of days. What's the rate of rise? These are all features that are important in determining kind of the cause of jaundice in your baby when you're kind of first starting out with the baby and you're maybe not really sure what's going on other than the baby's jaundice. So there's two different types of jaundice or hyperbilirubinemia, right? There's just physiologic or there's pathogenic, which is the bad one, which are some things happening. There's a disease process happening that can be, detrimental to the baby if we don't intervene. And remember that bilirubin production is just a part of the body's natural way in dealing with red blood cell breakdown. Just because there's jaundice doesn't mean that there is something pathologic or harmful going on. Physiologic jaundice can require intervention or medical treatment, but doesn't mean there's a pathological disease process going on. And to kind of figure that out, you have to go back to the very first little section that talks about the timing, the onset, and the rate of rise. So a lot of our infants in the NICU require phototherapy simply because they're premature and they have those risk factors that we kind of talked about. And even when you look at late term or a term and late preterm infants that are readmitted to the hospital in the first 2 weeks of life, so they go home and then they're readmitted in the first 2 weeks of life because they've got an increased bili level in their pediatrician's office, maybe let's say somewhere between like 18 and 20. Only really about 5% of those infants that are readmitted have a discovered pathological condition for their hyperbilirubinemia. So they're admitted for hyperbilirubinemia, they're treated most likely with phototherapy, but only about 5% of those babies really had something pathologic going on. So often it's just this physiologic process that is just the bilirubin level just keeps climbing and the body these babies just need a little bit of help clearing it. There's not really something pathologic going on. And just again, that timing and the onset and the rate of rise, it just helps to determine if it's physiologic or pathogenic in nature. Both might have some sort of intervention though, like we talked about. One thing I think is important to kind of remember is that when you're evaluating jaundice, any jaundice that appears within the first 24 hours or increases rapidly and it crosses the percentiles on the graph that I'll show you in a little bit. It's actually the next slide. So you've got jaundice in the first 24 hours, it's increasing rapidly, and it's crossing percentiles. You have to consider that that's pathogenic until proven otherwise. So that's kind of when you dive into more of those other labs that we'll kind of talk about, but maybe a CBC or a Coombs test. So you're kind of going to go a little bit further than just a total serum bili, because this kid is jaundice early. That bilirubin level is climbing pretty fast, and we're crossing percentiles. So we need to figure out what's going on. Why is this kid having so much red blood cell breakdown? And treat it. So we're gonna be concerned that this might be pathogenic until we prove otherwise. And it's kind of a proving by elimination. So all the labs look okay. You sort of consider more physiologic than pathogenic. So another concept that I think is important when you're talking about hyperbilirubinemia, and I mentioned this earlier, but just to mention it again, is that when you're talking about hyperbilirubinemia and the breakdown of red blood cells, this results not only in an increase in the byproduct of bilirubin, but also a decreased number of red blood cells, which leads to then having a low hematocrit and then concurrently being anemic. So it's almost like battling two conditions at the same time. Usually babies that have just physiologic jaundice, even if their bili is fairly high, even if they require phototherapy as treatment, they're not going to be anemic. The anemia comes into play when you have a pathologic condition happening where you've got an extreme amount of hemolysis happening and you have the baby's red blood cell production, so the bone marrow just cannot keep up, and you've got this anemia, low hematocrit, low hemoglobin, high reticulocyte counts happening. And we'll talk a little bit more about the lab work kind of like moving forward with each kind of condition, and they will make a little bit more sense, I think. I thought that these AAP recommendations, they kind of both encompass timing and onset in their statement for preterm and then for term. And I just wanted to kind of read them to you because I think they're good. So the AAP recommends, these are just general quotes, that recommends laboratory evaluation for the cause of hyperbilirubinemia in infants of 35 weeks gestation or more whose total serum bili levels exceed the 95th percentile, or in whom the rate of increase or the rate of rise appears to be crossing percentiles. And then the preterm down there, pretty much laboratory evaluation when the infant meets phototherapy thresholds. So we're a little bit more cautious with our preterm babies. We don't really wait for them to get to that 95th percentile before we might kind of throw an extra lab or two in for kind of figuring out if we've got a pathologic condition going on. We're a little bit more careful with them. And this next slide, whoops, let me just do it. So this is just a picture of the nomogram with the percentiles. So obviously the bottom line is the low risk zone here. And then you've got this low to intermediate risk zone, and you've got this high intermediate risk zone. And so if you've got a bilirubin level that's going like this, or more even like a straight line up, like that's concerning, as opposed to say you kind of just have one that's kind of trending, like maybe it's getting a little higher, but it's sort of trending still kind of on a nice curve with the line for your low intermediate risk zone. That's not as concerning as a bilirubin level that just goes dink and goes way up. So that would be worrisome. This is kind of the graph that is like the standard nomogram for evaluating total serum bilirubin levels in babies that are 35 weeks and older. So if you look down here, the solid line is infants at a high risk. So these are 35 to 37 and 6-week babies plus risk factors. And then if you go down here, it talks about risk factors. So you know you have like an isoimmune hemolytic disease like RH, ICO immunization. You know you have a G6PD deficiency, which we will talk about. You know you have asphyxia. You know, or you evaluate that you have significant lethargy, or you have temperature instability. So if you have a 35-weeker with any of those risk factors, that is the line that you are going to follow. This hashed, kind of like dashed line is infants at medium risk. So these are greater than 38-week babies plus risk factors, or 35 weeks to 37 and 6 weeks and well. So you have just a 35-weeker, that's a term baby, or that's a well-appearing baby, just eating, keeping its temp up, pooping and peeing, doing all the things a term baby should do. That you could possibly evaluate them at this dashed line, as opposed to this line down here. This top line here with the dots is infants at lowest risk. So these are 38-week infants and well. So these are pretty much your newborn nursery babies right here. So you just plot your babies. So you've got a kid at 24 hours old, because that's about when we check a first bilirubin level. And it's a 39-weeker, and it plots at, let's just say right here. Plots at, let's say it plots here, 9. If you can see my cursor, let's say it plots at 9. It would not be phototherapy threshold, so the infant would be okay. If it plotted up higher here, then maybe we would think about some phototherapy, but yeah, you just kind of go along, and remember that as the baby gets older, your level can be a little bit higher and be okay. So always keep in mind these risk factors, though, that we kind of talked about down here. And this bilirubin, this link here, should we see if it works? Oh, it's going to work. This is exciting. So this is like the go-to for bilirubin evaluation. If you don't have that nomogram right in front of you, you can just go to this website, because we all have computers in front of us all the time, bilitool.org. And then I always do this option 2 down here, age and hours. So we'll say the baby's 36 hours old. I'm just randomly picking numbers here. Let's just say the bilirubin's 10.9. You hit submit. And it is saying that this baby that's 36 hours old, that's got a bilirubin of 10.9, is high intermediate risk. And then you can come down here, and it kind of gives this recommended follow-up down here, kind of when to evaluate your total serum bili, or TC bili. Again, and if you go down here, then this is the AAP's phototherapy guidelines. So this is evaluating, like we talked about with risk factors, the neurotoxic risk level. So if this baby that's 36 hours old with a bili of 10.9 is a 40-week baby, then we do not need to start phototherapy. Their threshold is about 13.6, or though people will say their light level is like 13.6. As opposed to, let's say we've got a 35-weeker, maybe this 35-weeker has like some temps or something like that, where it's kind of like questionable right on the line. But we would definitely start phototherapy regardless, because their phototherapy threshold or light level is 9.6. So they have exceeded that, and it is recommended that they go under phototherapy. There is also an option to click here. I'm not going to do it, but you can click here, and it will take you to an exchange transfusion chart. So it will show you the level that the baby would qualify for an exchange transfusion. If you have a kid that, let's say, instead of this high intermediate risk, let's just go back here for a minute. Let's put in that the baby's bili is 16. I don't know what this is going to do. We'll see. Yes, high risk. So even for a term baby, low risk, and this neurotoxicity risk level, if you go over here, this is kind of the things that put you at higher risk, kind of the same as what we talked about earlier. So their light level is 13.6, and we've got a light level of 16. We've got our bilirubin level of 16. So then it even red flags it down here for you. It wants you to look at these exchange transfusion recommendations. So we will click on that. So we're 36 hours old, and we said that our Billy is 16. So we are right there. So we are on this solid line for infants at high risk, but our babies say 40 weeks. So our exchange transfusion level for this baby is really not till 21. So we're still okay. If the baby was 36, 35 weeks, we would maybe be thinking about it, or at least checking a Billy every 4 hours like crazy and triple phototherapying that baby. But for our term baby that's we'll say 40 weeks, we're okay because our light level or our level for exchange transfusion is way up here, 21. Okay, hopefully that makes sense. I have to think about how to get back to my PowerPoint here. Okay, good. Moving on. Okay, everybody needs to stand up and stretch and take a drink. I'm going to take a drink and take a deep breath because we're like halfway through. And we're back to this slide that maybe is familiar. Maybe you've forgotten it because I've talked your ear off now for too long and you can't remember it. But this is the slide that was like right up towards the beginning of the PowerPoint. Remember, these are three. We're kind of like to summarize kind of where we're at. We've talked about we've talked about bilirubin metabolism, where it comes from, where bilirubin comes from. That we've talked about the differences between types of bilirubin, and we've talked about risk factors for hyperbilirubinemia. And then we've talked about kind of those important concepts like rate of rise, timing, and onset. When we're thinking about whether jaundice is or hyperbilirubinemia is physiologic or pathologic, whether kind of differentiating between those two problems. So now we're going to kind of move into more of those clinical conditions associated with hyperbilirubinemia. We're going to talk about the most common ones. And I just wanted you to keep in mind these three concepts again. These are kind of the general events, if you will, in the body that cause hyperbilirubinemia. So you've got an increased rate of production. So you've got it being produced too fast. You've got reabsorption of bilirubin into the plasma from the gut via that enterohepatic circulation. Or you've got the inability of the liver to clear sufficient bilirubin from the plasma. So the liver is not working well. So those three kind of general events or conditions, scenarios, whatever word you want to use, are usually why the body is having this hyperbilirubinemia. This talks about the laboratory evaluation of a jaundice infant. It's a table in the Fanaroff book that is at the end of my references. It's a great reference. It's got a long chapter on neonatal bilirubin or neonatal hyperbilirubinemia. When jaundice is present, so it gives you indications and assessments. And the caveat to this, and so I have a star in the second box here underneath indications, is that often when we have our preterm infants, we have kind of a very low threshold for phototherapy for our preemies. And we know that they have special risk factors that make them more susceptible to jaundice, right? We know their livers aren't working. We know their guts are sluggish. So we often don't have to go beyond total serum bili checking, engine treating with phototherapy to help our preterm population with hyperbilirubinemia, right? They really don't usually need anything else. They don't have weird red cell enzyme deficiencies. They usually don't have like an isoimmune hemolytic process. So they usually just are early. They've got organs that don't work so great, and they need a little bit of phototherapy. So that's kind of my caveat because, as you can see, the If jaundice in the first 24 hours, if we just start at the top, then they want you to do the AAP. When I say they, I mean the AAP. If I ever say they, that's what I'm talking about. TCB or total serum bili. So the TCB is a transcutaneous bili that's often done. It's just kind of that meter that goes across the forehead, and it measures saturation in the fatty tissue of your skin and gives you kind of a reading. And it can be kind of accurate and kind of not accurate if you've ever used one. So take it with a grain of salt. It's kind of nice to not have to poke the baby in newborn nursery if you don't have to, because it's pretty specific where if it's low, it's probably low in the blood. If it's high, it could be low or could be high in the blood. So if it's low, you can be kind of confident that they don't need another serum bili unless you're like just really, really, really nervous about the level of jaundice that you're clinically seeing. So if you have an infant that meets criteria for phototherapy, so their bilirubin has reached that light level, that we would plot them on that graph, and then we have a rapid rate of rise, or we have crossing of percentiles, that kind of spike in bilirubin level. Then what the AAP says is to do all of these things. So blood typing in Coombs, a complete blood count, and we're going to talk about Coombs because it was confusing to me when I first started out in this NICU world, but I'm going to help everybody out in case you might know what it is, but I was confused, so we're going to talk about it. A complete blood count, a reticulocyte count, a blood smear examination, so they just put it on a plate and just look at it under a microscope to kind of see what the shape and what the blood cells look like. And then a direct or conjugated bilirubin. And then if they qualify for phototherapy, you're going to want to repeat their total serum at least in 4 to 24 hours. And this is considered G6PD testing. Most people would not do this at this point, but it kind of lists that every assessment underneath that as you kind of go through. And remember, a lot of these labs have to do with the fact that because we've got this rapid rise of bilirubin, we have what we have to assume is hemolysis happening. And so we're worried about being anemic. So our CBC is to check our HNH, our hemoglobin and our hematocrit, our reticulocyte count, which are our premature red blood cells. We're checking to see if the bone marrow is just like kicking those suckers out like nobody's business. If it's really high, it can be an indication that baby's really anemic. So, and then we just want to get a direct to make sure that we're going to treat this baby with phototherapy. Is it really an unconjugated hyperbilirubinemia? Probably, but you always want to check. So, and then moving down, you've got a total serum bili concentration approaching an exchange transfusion level. Or maybe you have a baby that's not really responding to phototherapy. They recommend that you do all of the above and the G6PD testing and an albumin level just to check to see if you have enough albumin to be able to carry that bilirubin to the liver. If you've got an elevated direct conjugated bilirubin in the liver, we're not going to talk about this a lot, but it's mentioned just a little bit, like a smattering of it here and there, because it's not super duper common, but we see it. So if you've got a conjugated hyperbilirubinemia, then you want to do a urinalysis and a urine culture and an evaluation for sepsis if the clinical history or the physical exam kind of indicates it. And also, this isn't listed here, but you would maybe want to probably do like a abdominal ultrasound to kind of see if there's anything going on with that gallbladder. So you've got all this conjugated bili in the liver. Why isn't it getting to the small intestine? Maybe you have something going on with your biliary tract, like an obstruction or something. And then jaundice that's present at or beyond age 2 to 3 weeks, or you've got a sick infant, then these are kind of the assessments that they recommend. So looking for more, obviously, of the kind of the zebras of diagnoses, not the most common ones that you see. Okay, so we are going to watch this a little bit more of this video, and I'm going to just fast forward to a little bit of a further along section here, so bear with me.
Jaundice, which doesn't have the most intuitive name, comes from the French jaunisse,
Okay, here you go.
hepatocytes that just can't work hard enough and keep up with a
Conjugated bilirubin is not excreted because it's not water soluble.
Don't pay attention to this. They're going to erase
In the
all
previous
this.
two cases, too much unconjugated bilirubin was created.
This is what I want you to listen
But you
to.
can also have hepatocytes that just can't work hard enough and keep up with a normal load. Physiologic jaundice of the newborn is one of these cases. Newborn livers have a lower amount of the enzyme UGT in the liver to convert unconjugated bilirubin. And after birth, unconjugated bilirubin levels can be high due to the natural process of macrophages destroying fetal red blood cells. Typically, this is normal, but there can be complications if unconjugated bilirubin rises a lot. Since it's fat-soluble, it can collect in the basal ganglia of the brain, which is also called kernicterus, and cause damage to the brain or death. Treatment of this condition is usually phototherapy, which uses light to induce structural and configurational changes in the bilirubin molecule. Basically, it absorbs the energy from the light and changes shape. And these new shapes are more soluble and can be excreted in the urine. And this can be a super effective and non-invasive way to get excess unconjugated bilirubin out of the blood. Another potential case where not enough unconjugated bilirubin can be conjugated is through hereditary defects. One case is called Gilbert syndrome.
Okay, we're not going to go into those genetic defects in this lecture. We'll save that for another time. But I just kind of thought that was a nice little overview of the physiological jaundice. So here are just some types of hyperbilirubinemia. You have physiologic jaundice, you have pathologic jaundice, there's breast milk jaundice, there's breastfeeding jaundice, there's hemolytic jaundice, and then like kind of what I've talked about, the different causes. You have increased production, you have decreased hepatic uptake. These are just general causes of neonatal hyperbilirubinemia: impaired bile flow, increased intrahepatic circulation, impaired excretion, decreased conjugation. So hopefully kind of as you look at the causes now that we've kind of talked about the processes, you sort of understand and can say, oh, I know now if there's decreased conjugation why that would cause a problem, because the baby can't get rid of it. Or if there's impaired excretion, the baby can't get rid of it. So if there's increased intrahepatic circulation because the bilirubin is sitting in the liver or the small intestine because the baby's not eating, I get why that would cause an increase in my jaundice level. So I'm going to read my notes here really quick and see if there's anything else that I need to talk about. We really could be here all day probably talking about the different reasons why a baby could be jaundiced, but like I said, we're going to focus on kind of the more common ones. And I had a note to kind of talk about the anemia part of it, but we sort of already did that. Because our babies aren't so great at replacing losses. If we've got a lot of this lysine or hemolysis breaking down our red blood cells, it can mean anemia or a lack of red blood cells. And so that can cause kind of a whole nother set of problems. We don't want our babies to be anemic. We want them to have enough red blood cells to perfuse their organs and tissues and to be able to grow and to thrive. So that obviously is something that is important. This from a book. I did not make this fabulous graph or diagram picture, but it's a nice summary. So I wanted to include it of different types of unconjugated hyperbilirubinemia we see in newborn infants. So we're not going to talk about all of the ones that are on this list, but remember that indirect or unconjugated hyperbilirubinemia is a little bit more common. And so these are kind of the situations that could occur in a newborn infant. You have different categories of hemolytic disease, which we will talk about those too. The heritable ones, so you inherited this from your parents, it's genetic. So that's some of those red cell membrane defects or enzyme deficiencies, the hemoglobinopathies. Other, I love it when there's like an other category, like we don't know, it's other. Sepsis, DIC, extravasation of blood. Oh, see, I said it right this time. Polycythemia, and then this is kind of where our IDM babies kind of come into. So it's increased production. That was one of the 3 concepts that I was talking about earlier. Increased hepatic circulation, intrahepatic circulation. This is where our breast milk and our breast kind of feeding babies kind of take up or kind of plot into. Pyloric stenosis, which we're not really going to touch on today, or if you've got some kind of an obstruction. So pretty much you've got this conjugated bilirubin sitting in your small intestine. It's not going anywhere for whatever reason. And this intrahepatic circulation is just going to be like, well, I'll take it back up to the bloodstream then. Decreased clearance. So our premature babies, super, super common for them to be hyperbilirubinemia, if that's even a term. And then our G6PD babies, which we will talk about this because you may see this. I mean, you probably will if you're a NICU nurse for any length of time. And then there's some metabolic conditions also. We're not going to touch on any of these ones. But one thing with these thyroid things is I did want to say, remember that your Down syndrome babies a lot of the time have thyroid problems, low thyroid levels. And so sometimes these babies can be a little bit more jaundice than what you kind of like are thinking they should be, if that's something that you'll remember. Well, all right, and just to differentiate these 2 terms again, because I think it's important, you've got physiologic and you've got pathologic. Physiologic is just that normal red blood cell breakdown. It occurs in more than 60% of term newborns and more than 80% of preterm infants. So it's super common. You'll see it all the time. It will become just second nature to you. But like I said, it can be kind of upsetting to the parents. And when baby's under phototherapy, mom and dad can't hold. They can't breastfeed as often as they want. So it can be kind of a point of hardness for the parent. They can be a little bit upset about it. So just to understand it, be able to help them through that. Physiologic jaundice, when available albumin binding sites are saturated, that unconjugated bilirubin circulates as free bilirubin and can cross the blood-brain barrier, just to keep that in mind. So that's why we treat it. Pathologic jaundice we see in the first 24 hours. So that baby's yellow like at hour 12 and you're like, pretty jaundice. I don't know. We should probably look into it. And sometimes it can be jaundice that lasts for more than a week in term and 2 weeks in preterm infants. So you kind of have to look at other clinical features with that one, but that could be something concerning for sure. Think hemolysis when you're talking about pathologic. So think anemia. Think red blood cell breakdown. My baby's not going to have enough blood now to perfuse all their organs. So that's something bad, and we need to get going on some treatment. Bilirubin levels usually peak on day 3 for term babies and usually by day 5 or 6 for preterm babies. So that's also kind of something to keep in the back of your head. Kind of will always see sort of a trend of a peak up and then sort of a trend down. We're going to talk a little bit about breast milk jaundice versus breastfeeding jaundice. So breastfeeding jaundice is just thought, well, we'll start with breast milk. How about since that's first, left to right? Late onset, usually after day of life 4 to 7. Usually peaks around 2 weeks, can remain elevated for 2 months. So this is kind of like the previous slide said something about jaundice lasts for more than a week in term and 2 weeks in preterm. Could be pathologic, yes. But if it's just kind of a lower level and baby's just sort of jaundice, breastfeeding fine at home, everything else is fine. Could maybe just be a little bit of this breast milk jaundice that can remain elevated for 2 months and can kind of ebb and flow a little bit too, depending on the quality and the properties of the breast milk itself. So, and it's caused by substrates in the breast milk that can just cause an increase in deconjugation and reabsorption of bilirubin. So it's not super well understood, but that's kind of the thought behind it. And so that's why it can last for a while. Breastfeeding jaundice, however, is usually found earlier on. It's thought to be kind of a combination of maternal and neonatal factors that result in a diminished fluid intake and dehydration of the baby. So it's usually early, 2 to 4 days of life. Poor intake leads to poor stool output, leads to bilirubin sitting in the small intestine, and increased intrahepatic reabsorption. Treatment is usually to just alleviate the dehydration with either more frequent breastfeeding or supplementation if the mom is okay with that, especially until the breast milk supply is established. So if it's early, day 2, then it might just be that the mom's milk is not in yet and the baby just needs a little bit of supplementation. So we can maybe encourage mom and kind of, I think, you kind of explain it and you talk about it a little bit and they get it. And maybe they'll be okay with a little bit of formula or donor breast milk until their milk is fully in. So some maternal factors that can also attribute to breastfeeding jaundice. I mean, think about, limited milk supply. Like sometimes you have these moms that pump and never get milk or don't ever get enough milk. Sometimes you have these moms that are so engorged that they just are having a hard time expressing milk, or they've got cracked nipples, or the baby's got some poor feeding techniques, or you've got moms that are sick. They don't feel good. They've got either they're really sick, or they've got they're just tired from delivery, or they're they were on meds because they had a C-section and now they're feeling lousy because of the meds. So if sometimes it's no one's fault. And I think that's another thing, when you're talking breastfeeding jaundice, sometimes you can have a little bit of guilt from the mom, but just to kind of help her and talk her through it is important. And then the baby, once that bilirubin level kind of climbs to a certain amount, you can have that poor suck, that lethargy, that poor feeding that kind of accompanies hyperbilirubinemia, and then it just sort of pushes them into the cycle of a higher bili because they're not eating as well, and it's just like a big circle, and then everyone's crying, and we want to avoid that. So phototherapy can be used in both of these conditions. Often it is not needed in this breast milk jaundice. But can be in the breastfeeding jaundice, especially if this is like a term kid that just like mom's trying to exclusively breastfeed. Now she's ready to go home and his bili is just too high. So needs a little bit of phototherapy because he's a little dehydrated. Or the kids you get from, like the MLB or the pediatrician's office where, they've gone home and now their bili's, 20 and because they're not eating and mom's milk isn't in, or, lots of different reasons that we just talked about. So phototherapy, give them a bottle, maybe an IV. It'll be all right. Hugs and kisses for everybody. And remember, both of those conditions too, sorry, one more thing. That's an unconjugated hyperbilirubinemia, right? Right. Okay, the Coombs test. Like I said, you might understand it better than I do, but when I first started NICU nursing, it was confusing. The Coombs, I don't know why. Probably because I just never took the time to really understand it, but we're going to talk about it. So it's not a mystery, and you get it, and you'll be so smart, way smarter than I was ever starting out as a NICU nurse. Is anybody here in this group listening understand the Coombs test and its function? If you do, I think you should give yourself a pat on the back because good job. So the Coombs test, I think, to sum it up, because I like to start with a summary, is done to answer the question of whether or not the infant's red blood cells are being hemolyzed because of antibodies from the mother. So remember, if you think back to that chart of the laboratory test when we had like the assessment or indication and assessment, the Coombs test, they wanted to do if you've had that sharp rise in bilirubin or crossing of the percentiles for the bilirubin level. So you've got like a kind of a sharp trend up. You've got a fast rate of rise, and you want to know what is going on, and is this attributable to hemolysis, And is it because mom has antibodies that she's made that are now attacking baby's red blood cells and making them hemolyze? So the Coombs test are done to find certain antibodies that attack red blood cells. Remember that antibodies are proteins made by the immune system. Everybody does this, thank goodness, naturally. Normally, antibodies bind to foreign substances such as like bacteria and viruses and cause them to be destroyed. But in this case, the antibodies are formed by mom against the baby's blood type and are transported across the placenta because they're IgG and they can give them to the baby. And they are attacking the foreign infants' red blood cells and destroying them. So I say foreign because it's foreign to the mom's system. They have a different blood type than baby. And this can cause hemolytic jaundice when it happens. It can be a significant cause of anemia when it occurs in its most severe form, which we'll talk about in a little bit. And so we often do this to just assess whether that is happening or not. So there's two different types of Coombs tests, and they're both detecting antibodies on a red blood cell surface. It's just talking about what red blood cell we're looking at. So the direct Coombs test is kind of a measurement of presence of antibodies on the red blood cell surface of the baby's blood. So we do a Coombs test on baby's blood, and a positive result means that baby's blood has antibodies against their own Rh or ABO antigens, against their own blood type. So that's not good because then we're going to have hemolysis. An indirect Coombs test means that we're measuring the presence of antibodies against baby's blood in mom's blood. So on the surface or just floating around in mom's blood. So a positive result for an indirect Coombs test means that the mom had antibodies against Rh or ABO antigens of the baby, and they're floating around in mom's. Okay, though the indirect Coombs test, if that's positive, that's really kind of bad because the mom has these antibodies against the baby's blood are still floating around in her bloodstream, and that's why this baby all of a sudden, its hematocrit's super low and its bilirubin sky high, and now we are doing a double volume exchange transfusion. So if you don't understand that, email me and we can, or stop me on the unit or something, and we can talk more about it. But and I just wanted to put in this antibody test or a DAT test, direct antibody test. So you will hear it called DAT or antibody tests, like people use those terms interchangeably, which is probably why all of medicine is confusing because there's always like two names for the same thing. But this is a prenatal test that they do for moms, looking for antibodies in mom's blood against different blood types other than the one she is. And so if that's found, because she had a miscarriage or she had an abortion, or maybe she didn't even know she was pregnant and had something like that. So if she has a positive antibody test, she will probably get RhoGAM in her pregnancy, which just will help with those antibodies that she's now formed. So like I said, if it's confusing and you're not real clear on that still, let me know and we can talk more about it. But we're going to move on. This is just kind of a summary of what we just talked about. Direct Coombs is looking for antibodies that are attached to the infant's red blood cell, potentially cause of the hemolysis. Positive Coombs is often found in ABO incompatibilities or Rh incompatibilities. A negative Coombs, you can kind of assume that there's no hemolysis, or there could be hemolysis, but maybe it's not involving antibodies. Could be maybe like a defect in red cell membrane or something like that. And then the indirect is looking at antibodies in the mom's blood. And then just a little bit about the antibody screen down there. So if you have an ABO setup where the mom's O, let's say, and the baby's A or B or AB, then you will more than likely have a jaundice infant because she is going to have antibodies against A and B if she's O. And especially if you're Coombs or is positive, your drug Coombs for the baby, or you have a positive antibody test, then you kind of assume you're going to have a jaundice infant to deal with at some point. It's probably going to need some intervention. I'm hoping that this little video down here works because it's short and sweet, but it just sort of talks about ABO incompatibility.
In order to understand ABO incompatibility, we must first understand the genetics of blood typing and the inheritance behind it. There are 3 different blood types, A, B, and O. O is recessive, while A and B are equally dominant. Each parent will have 2 copies of each type. Because O is recessive, there's only one possible combination. For A, there are 2. For B, there are 2. For every blood type, there will be antibodies against its opposite. For A, antibodies against B. For B, antibodies against A. And for O, antibodies against both. These antibodies are free-flowing in the mother's blood and don't require sensitization to be made. So the problem is when the mom has O-positive blood and the baby does not. The mom then carries antibodies that can be harmful to the baby's blood and could cross the placenta and cause hemolysis.
Created using Powtoon.
That video always ends so abruptly. It always startles me. I've watched it a number of times and it always startles me. So ABO incompatibility, this is just one of our hemolytic jaundice that's pathologic. So, you have a bilirubin level that's high, and it's not just a result of being premature with immature livers or physiologic. It could be pathologic. It really could result in active gross hemolysis and anemia. This one's not quite as bad as the other one we'll talk about, the RH incompatibility, but it can still cause problems. So we've got a mom who's O, we've got a baby who's A or B or AB. We probably have jaundice in the first 24 hours. Minimal anemia, it varies by baby. It can be minimally anemic all the way up to, moderately anemic, I would say. This just happens, you can't do anything about it. It's just the way you are. You just receive a certain blood type depending on your biological dad and your biological mom, and it's part of your genetic makeup. And these antibodies that mom makes, because she's a certain blood type and baby's a certain blood type, they just readily cross the placenta. And so there's not a lot that you can do about it. Interesting enough that when you have the scenario of mom being O and baby's A or B, 45% of Americans or Western European descent are group O, with a similar percentage for A. And so often, most commonly found incompatibility in the US is between A and O. So if you've got a mom that's O and she's got a baby who's A, that's going to usually cause problems. And sort of as you kind of start to work in the NICU, you'll kind of find that those babies who are A, moms are O, tend to be a little bit more jaundice and their bilirubin levels higher. So we would do probably an antibody test on mom, and if she's positive or baby's got a Coombs positive test, then that would be more concerning, right? Because we have those antibodies that are present. If the Coombs is negative, there's not a real risk for anemia. There could still be some jaundice though. And if the Coombs is positive, they may develop significant anemia or jaundice. This can kind of this ABO incompatibility can cause a fast rise, and then it kind of slows down. Usually not associated with kernicterus or neonatal bilirubin encephalopathy, regardless of how high the bili rises. And this is an unconjugated hyperbilirubinemia. So this is the bilirubin that's not conjugated in the liver, right? This is before we get to the liver. We've got a lot of this unconjugated hyperbilirubinemia because of red blood cell breakdown. Now, this condition, so this is another example of a hemolytic jaundice that's pathologic, Rh isoimmunization, another unconjugated hyperbilirubinemia. This is talking about Rh. So you're either Rh negative or you're Rh positive, and then you've got your blood type A, B, O, or a combination of one of those. So anti-D antibody is kind of what we're talking about here. This mom will probably be antibody positive and Coombs positive, and you have exposure to fetal antigens that cause mom to produce antibodies. So mom is negative, baby is positive, and she produces these antibodies against positive baby. They cross the placenta and they attack the baby's red blood cells. In the next slide, we'll talk about a condition called erythroblastosis fetalis that can result in hydrops. It's kind of an interchangeable term. It can be a nasty condition for babies that can cause severe anemia. So this will increase with severity with subsequent pregnancies. These are the moms that get ROGAM. There's a rapid rate of rise in bilirubin. Not seen very commonly anymore, thank goodness, because we have good prenatal care. First pregnancy is what exposes mom. So like the thing is that let's say mom got pregnant and didn't know she got pregnant and miscarried, and that fetus was positive, Rh positive, and she's Rh negative. She could have created antibodies that will now cause issues for her next pregnancy. But if she didn't know she was pregnant in the first place, when she goes to the doctor and they say, have you ever been pregnant? And she says no, then that's kind of where the issue kind of comes in to play. So it's first pregnancy, remember, not first baby. So miscarriages, spontaneous elective abortions. If mom is in a car accident, she falls down the stairs and she's pregnant and they know that she's Rh negative and baby's Rh positive, they will go ahead and give her a dose of ROGAM. So anything that can expose her body to more of the baby's blood type and cause her to make more antibodies, that would be something that would need to be treated with ROGAM shot. And what can happen if we don't treat this and mom's red blood cell or mom's antibodies are really attacking baby is we have what's called this hydroptic fetus or hydrops fetalis, an intrauterine form of heart failure often due to fetal anemia. There's two different types. It can be a complication of that Rh isoimmunization that we talked about on the last slide, but it doesn't have to be. Immune hydrops is when you have mom's fetal red blood cells enter maternal circulation and you have maternal antibodies that then cross the placenta and attack and destroy fetal red blood cells. Not commonly seen in ABO incompatibility. I'm sure it can, but it's just not as common as like Rh isoimmunization can be a cause of this. So the other type is the non-immune hydrops, and this is because you just have some disease or anomalies, let's say cardiac anomalies or something along those lines, where you have just a poor cardiac output, and then you have bad blood flow to organs, and you have kind of anemia that can interfere with growth and the way they manage fluids, and you have kind of a generalized subcutaneous edema and fluid in like 2 compartment spaces. So you can have liver dysfunction, you can have gross edema, you can have portal venous hypertension, you can have ascites. These babies have pleural effusions, maybe even pericardial effusions. They are very, very sick, require a lot of intensive treatment in the very first week or so of life. a lot of it can be caused just from the congestive heart failure or from like an intrauterine hypoxia from severe anemia. So that would be the intrauterine hypoxia with severe anemia can be more of the immune scenario, whereas like a congestive heart failure can kind of be more of the non-immune scenario. So immediate delivery room management is usually airway first, of course, intubation with elimination of extra fluid through like a thoracentesis. So you insert a needle between the pleural space and the lung where that fluid has collected, or a pericentesis for ascites. Same idea, you take out the fluid that's now accumulated in the abdominal area. Volume replacement and vasopressor support are very important and probably on the menu of things that you will be offering this baby to get them to survive. They're usually very sick. And this was a very mild picture here I found. If you Google hydrops, like it's not for the faint of heart because there are some horrific pictures of these poor babies that are just miserable. So I warned you. That's all I'm going to say about that. Okay, so treatments. We've kind of talked about some of them, but phototherapy obviously is something that we see a lot. Light therapy, and that's for our unconjugated hyperbilirubinemia. We can give intravenous immunoglobulin or IVIG, which just kind of protects against hemolysis. So if we've got a kid with maybe like an ABO incompatibility or like an RH isoimmunization that we know we have hemolysis because we've had some positive Coombs tests or positive antibody tests, we can give us some doses of IVIG, kind of coat those red blood cells and help them, protect the ones we have against the antibodies. And it's given intravenously. Phenobarbital. This helps if you've got a conjugated hyperbilirubinemia. So it increases your bile salt. Remember, it sits in that gallbladder, that conjugated bilirubin. So if you kind of increase that bile excretion or that bile production, then it can kind of push that conjugated bilirubin out of there and into the small intestine. If our unconjugated bilirubin gets too high, we can do an exchange transfusion. So greater than 25 is not an absolute number, but often seen with bilirubin levels that high. These babies will need a double volume or single volume exchange transfusion where we take out their blood volume using the UV line, the umbilical venous line, and the umbilical arterial line, and we give them new blood that does not have, that is not going to be hemolyzed. And then oftentimes we need to treat the underlying cause. So if they're infected, if they're acidotic, they're not going to be able to manage their bili load as well. And so if we treat those two conditions, then the bilirubin will usually improve. At least it will help it improve for sure. I wanted to talk a little bit about phototherapy and kind of how it works, some of the risks, because I think it is a pretty benign treatment, but it's not without its risks, especially for our preterm babies. So we can do a single, a double, or a triple bank. I even saw somebody try to do a quadruple bank. I'm not really sure that worked super well, but it was done. We can do a kind of a neo blue. So there's a blue light, big blue bank light. We can do a spotlight. We can do a bili blanket. So they can kind of sit on a blanket that emits light. There's different forms of phototherapy. And how it works is it just changes the shape of unconjugated bilirubin to a water-soluble form and excretes it so it can be excreted by the kidneys and the intestines. So it just goes through a molecular change due to the light, and then your body can get rid of it. It's a lot more complicated than that, but that's as complicated as we're going to get today. And that's really all you need to know. Bilirubin absorbs light most strongly in the blue region of the spectrum of light, the blue-green region. So that's kind of why our neo-blue lights are the most effective and treat the best. And the penetration of tissue by light increases markedly with increasing wavelength. So the irradiance is the efficacy, and it depends on the energy output. It's kind of like what we measure. So the distance from the light from the baby, when we measure our irradiance level, we're kind of measuring that wavelength. We want to make sure and cover our baby's eyes and hydrate them because this can cause them to have a lot of insensible water loss, even our bigger babies. We want to make sure and hydrate. And then the AAP guidelines, that nomogram, gives us kind of an idea of when to initiate treatment and when to stop treatment. So the risks are we've got retinal damage because it's a light, right? So that's why we cover the eyes. They can have diarrhea just from a little bit of dehydration. Bronzing is something that we see if you've got a conjugated bilirubin level and you light a baby up. You may actually cause their skin to change color permanently. It is irreversible. So it is not a bad idea to do a fractionated bilirubin level or be fairly confident that what you're treating is an unconjugated hyperbilirubinemia. And then not really a risk, but just sort of a factor is it interrupts bonding, of course, because the baby has to be underneath the light. And so mom can't hold and snuggle the baby like she wants to. And so sometimes that can cause a little bit of unrest with the parents. This is that nomogram that we talked about, determining the light level with the graph, tells you when to start phototherapy. There's 3 different groups. We've talked about them depending on their gestational age, and then it always takes into account here on the x-axis is the birth time to hours old, and over here on the y-axis you've got your total serum bilirubin level, and you just are going to plot your baby somewhere on the graph. Next we have, we're almost done, guys, hang in there. So the graph, actually, I'm going to go back a minute. So as you can see here, this is infants at higher risk. So this is 35 weeks. But what about our babies that are less than 35 weeks, right? How do we know when to start phototherapy for those kids? So there's been some literature that's come out with some guidelines for our little babies. And this is an example of that. So we have like less than 28 and 0. We initiate phototherapy with the total serum bilirubin level between 5 and 6. And then it gives exchange transfusion recommendations of a total serum bili for that same age group of 11 to 14. And you would also look at kind of the clinical picture of the baby too, you know, are they sick? Are they acidotic? Are they NPO? Are they not able to eat? You know, what's going on? But obviously you would treat in these ranges. And then it just talks about the additional gestational ages here, 28 to 29 and 6, 30 to 31 and 6, and so on. And as they get bigger, they're able to tolerate higher loads because their organ systems work better. This is just another chart. It kind of gives the reference down there. It came out of the Journal of Perinatalology, and it was a consensus of recommendations. The same actual values are on this table. So just kind of 2 different tables from 2 different references saying the same thing, which is always a good thing if you're thinking about what to treat off of. Okay, this is sad, but this is what happens when we don't get treated appropriately. So neonatal bilirubin encephalopathy, or kernicterus. So this is a baby with, now, you know I can't pronounce things, so opisthonotosis, I think is how you say it. That arching of the back with the head kicked back like that, kind of rigid legs, sort of hyperextended. So free bilirubin has crossed this baby's blood-brain barrier and has now resulted in neurotoxicity to some of his brain cells. Acute encephalopathy, we used to not really be able to diagnose this except with autopsy and call it kernicterus, but now we do have some MRIs that are able to see the yellow staining in the nuclear centers of the brain, so we can sort of call it what it is. So we prevent this by not letting the bili get too high, by initiating phototherapy, intensive phototherapy if we need to. We don't let the bilis exceed 25 or 30. We do double volume exchange transfusions. So we treat babies before they reach this threshold. We don't even let them get close usually. Everyone gets really nervous when they reach that exchange transfusion level, and that's hopefully lower than what it would need to be to cause this terrible condition. These babies are miserable. It can result in hearing loss, cerebral palsy, intellectual disability. They have a high-pitched, shrill cry, and it can even cause death. So we want to avoid this. Nobody wants to see this. It's not good. And there's different stages. There's different stages to this encephalopathy, this neobilirubin encephalopathy. So this is a very brief overview of this, and there is references at the end of the PowerPoint if you kind of want to read a little bit more about it. Kind of a 3-stage process, so we don't want to see it. G6PD, I included this, an unconjugated hyperbilirubinemia. It's because of a red cell enzyme deficiency. It's fairly common, affects about 12% of African American males and 4% of African American females. I don't know if it's a very common, that was probably not the right verbiage to use, but it is common enough that you could see it. So it's an X-linked disorder, and it can often be managed with medication. It stands for glucose 6-phosphate dehydrogenase deficiency. You don't have to write that down, but and babies pretty much, they lack an enzyme that prevents their red blood cells from breaking down just from daily stress and oxidative damage. So this is kind of something they struggle with throughout life. You know, daily stress will help break down your red blood cells, or if you've got, like, you know, you're sick, you're going to have more red blood cell breakdown. So as they have increased production, because they don't have this enzyme to kind of protect the red blood cells, they can struggle with hyperbilirubinemia. Usually can be managed with a medication, and they do fairly well. We just have to catch it and manage it. So wanted to say a little bit about that. And then I wanted just to briefly kind of talk about elevated conjugated hyperbilirubinemia and kind of the conditions that you'll see this happening. It's never physiologic or normal to have an elevated conjugated hyperbilirubinemia. It's your direct or conjugated bilirubin should never be above 1. People get nervous if it's kind of close to 1. A little bit can result with the hemolytic process. So like your babies that have RH isoimmunization or ABO incompatibility, because they've got kind of a lot of hemolysis going on, they can have a little bit more direct bili than the average baby. But if you've got you fractionate it out and you've got more direct, a higher percentage, 3/4 of your total serum is direct, then you know that's not normal. So biliary atresia or obstruction can be a cause of this, right? Because that you're not getting that conjugated bilirubin into the small intestine. So that makes sense to my brain. Hopefully it does to yours. Liver cell injury from like prolonged TPN use or infection. Certain medications that can cause liver damage, like a metabolic derangements or like an inborn error of metabolism. So you've got liver that's not cells that aren't functioning or they're injured. So that's going to affect your conjugation, right? And so you can have kind of an elevated conjugated bilirubin. The liver's not working right. Elevation of direct conjugated level greater than 1 is cause for investigation. And usually that starts with kind of an imaging of the biliary ducts to see if you've got kind of an obstruction somewhere. And then you kind of get more into the other kind of like hemoglobinopathies and things like that that you kind of do in some kind of genetic labs for, and we're not really going to get into that today. Most commonly, when you have this in our preterm populations, it's because you have cholestasis, which means you have a reduction in bile flow, and you have this because we use TPN too much. And it's way better than it used to be. But still, you think about your chronic kids or your gut kids who have, gut surgeries and they're on TPN for a long time. They get this damage from the liver cell due to this TPN. It's hard on your liver, right? Your liver has to process all of that, and it just wears on it over time. So they can have a high direct bilirubin just because they've been on TPN for too long. And whatever the case may be, sometimes we can manage it with these medications. Ursodiol or Actigol is commonly seen with a high direct bilirubin level if we need to treat it. It just increases your bile salts again, along with phenobarbital. And then the ADEK vitamins, so Adex, this is the one that turns your poop and your pee orange. It's a good thing to know, especially to tell the parents. But these are your fat-soluble vitamins, right? And so if your liver is damaged, then your liver is not going to be able to process these vitamins for your body to use as nutrients like it needs to. So you really need to be supplementing your ADEK vitamins. So that's why we give them to these babies that are struggling with this. And then next, I think you guys were almost done. Sherry put this hilarious picture in. So today I learned that you should never breastfeed after getting a spray tan. That's funny. Know your resources. So there's going to be a policy here on hyperbilirubinemia. Know your policy for phototherapy. Maybe not on hyperbilirubinemia, but on phototherapy. Know that. Know your nomograms. You can click in the nurse view of your Cerner. If you look at the NICU nurse view kind of up at the top, you click on that. Go down to scroll to hyperbilirubinemia, click on that. It will kind of give you that percentile graph that I showed you, and will plot your baby in low risk, intermediate risk, high risk. And then I showed you the Billy tool. That's kind of a nice resource that you can kind of, you get your Billy back in the morning. You're wondering, photo, no photo. Plot them in there. Get online. Do it. See what you come up with. You'll be, people will be real impressed. I wanted to do one case study real quick before we're done. So you have an infant, a male infant, 35 and 3 weeks, an infant of a diabetic mother born via C-section that was described to you as rough, right? We've all had that report. It was a rough delivery. You're like, I don't know what that means, but it sounds not good. So after delivery, the infant appears to have mild bruising to the head in one extremity. Red flag, right? Risk factor should be like kind of ding, ding, ding in your brain. And then at 12 hours of age, the baby is described as mildly jaundiced with a total serum bili of 3.8, right? We normally do a CMP or like a BMP and a bili at 12 hours of age. At least in the NICU we do. And so we get the bili back. Our first bili kind of plots some benchmarks, and it's 3.8. So I just, I plotted it for you here so you could kind of see 3.8. I mean, I tried to get the 0.8 as best I could. So what are the risk factors for hyperbilirubinemia in this infant? His age, right? He's 35 and 3, so he's a little bit preterm. He's late preterm. A rough section, right? So just a little bit, I don't know, more handling of the baby than what was necessary, probably because he was macrosomic, big. He's male, so that kind of will put him at a high risk. And then, like we said, an infant of a diabetic mother, so he's probably going to be a little bit bigger, LGA, rougher delivery, kind of all can be kind of breaking up those red blood cells on the way out. Is this infant experiencing conjugated or unconjugated hyperbilirubinemia? What do you think? Unconjugated, right? Your total serum bili is elevated. You're jaundiced early, most likely unconjugated hyperbilirubinemia. Do you think, based off where this baby is plotted on the nomogram, that he needs to be treated? for his hyperbilirubinemia? Does this baby need phototherapy? No, right? Because if he's infant at high risk, so he's 35 and some change, we're not going to say, we'll even say, maybe he's in an isolate, or let's say he's got a low blood sugar. He is IDM after all, so maybe he's got some risk factors. So even if he was on this lower line, right, he's not well appearing 35-weeker, his phototherapy light level would still be 6, right? So we're well under that at 12 hours. We're okay. We're good. What orders from the provider would you expect moving forward? So this baby's in the NICU. Billy's 3.8. Really nothing other than the normal, right? Increase hydration as much as possible. Try to eat, try to poop, try to clear it himself. Everything will be fine, right? Maybe. So now your baby's 36 hours old. You get a report overnight, like you're back. You went to bed, you came back. Now you get a report that the infant did not PO feed very well throughout the night, and he's just gotten really sleepy. I just don't know why he won't wake up and eat. He's sleepy. I mean, he's IDM, so that could be a reason, but he's just won't eat, man. Couldn't get him to eat. Morning serum to Billy level has come back at 11. Ooh. Think about where your 3.8 was. Down here. And now we've like got crossing of percentile, just a little bit. Not very bad though, but do you think this infant's experiencing conjugated or unconjugated hyperbilirubinemia? Still unconjugated. Do you think this infant needs treatment for his hyperbilirubinemia? Okay, yeah, we should treat this baby because we've got, here is got some risk factors. Let's say he's well appearing. We're still like right there. I would treat him. It went from 3.8 to 11, so I think he deserves at least a Billy blanket. What orders from the provider would you expect for him moving forward? So phototherapy, you would be maybe thinking of a feeding tube if he's not POing, right? Maybe he needs a feeding tube in minimum volume if you don't already have an ordered minimum volume. If the mom's really opposed to a feeding tube, maybe you need an IV. Maybe you need both. It is LGA and IDM, so maybe the glucoses are crappy too. I don't know. We'll say it is IV. And then we would check a bilirubin in the morning. So we could do like an H&H or a check in the morning. That might be a little bit premature, but it wouldn't be outside the norm of somebody to order that. And just remember reticulocyte count, in case I didn't say, is just your immature red blood cells found in your state of anemia. Okay. So precursors. You guys, that's it. The baby's not going to get any worse. Your phototherapy cured him and we're done. Perfect. Let me know if you have any questions. Find me on the unit or email me. And thank you so much for listening. It's going to take me a minute to get over here and stop the recording. So thanks so much, and hopefully you learned something, and let me know if I can answer any questions for you. All right? Have a great day.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.